Hello, my name is Gina Tyler. I'm the mental health nurse educator.
And I'm Leah Romero-Klein. I'm the acute care nurse educator. And today we're going to go over the alcohol withdrawal treatment SOP. We'll go over the updates to that SOP for nursing. And we're going to include the use of the SOS score and the RASS assessment to monitor patients going through alcohol withdrawal, as well as talk about some updated pharmaceuticals that we can use for that treatment, including phenobarbital.
This SOP is intended to guide the initial management and care for patients with alcohol withdrawal, identify patients admitted to the hospital for another disease process who are at risk for or are experiencing alcohol withdrawal, monitor patients for signs and symptoms of withdrawal, and administer appropriate medications in a timely manner, minimize the adverse outcomes of alcohol withdrawal, such as patient discomfort, seizures, and delirium tremens, and avoid adverse effects of withdrawal medications, such as oversedation. AWS occurs along a clinical spectrum, can mimic other disorders, and requires attention to details such as alcohol consumption history, including recency of last reported intake, clinical history of withdrawal symptoms, and other factors. Alcohol withdrawal severity assessment scales should not be used as a diagnostic tool, as scores can be influenced by conditions other than alcohol withdrawal. A diagnosis of AWS is needed to initiate treatment for alcohol withdrawal. Patients at risk for complications from alcohol withdrawal should be considered for inpatient admission include those with symptoms of severe alcohol withdrawal, those with a history of withdrawal seizures or delirium tremens, those who are unable to tolerate oral medications to treat alcohol withdrawal, and others. While benzodiazepines have a longer therapeutic option, newer evidence guidelines, including those of the American Society of Addiction Medicine, incorporate other therapeutic options, including phenobarbital. Phenobarbital has been shown to safely treat patients in all areas of hospital, including the emergency department, inpatient units, step-down unit, and intensive care settings.
A symptom-triggered approach to administering pharmacotherapeutic agents, as opposed to a fixed scheduled dose, for alcohol withdrawal is recommended for most patients admitted to RMR VA. The Severity of Ethanol Withdrawal Scale, or SOS, has been found to superiorly measure alcohol withdrawal syndrome and to significantly reduce the time on medication procedures for treatment by greater than 1 day, and is the preferred scale for evaluation of the patients in the RMR. A SOS score of 6 or less is recommended as the goal of therapy, with ranges of 6 to 11 suggesting moderate symptoms and scores greater than or equal to 12 suggesting severe symptoms that may require escalation of pharmacotherapies to treat the syndrome. Long-acting benzodiazepines, whether intravenous or oral, are effective medications for alcohol withdrawal, and there is strong evidence for the use of phenobarbital in alcohol withdrawal as well. In patients with severe alcohol withdrawal who require intubation and mechanical ventilation, or for any patient who is overly sedated, the Richmond Agitation and Sedation Scale, or RASS, will be the primary scale used since a symptom-based scale cannot be used. A RASS score can be used synergistically with the SOS score to determine additional medication needs in non-intubated patients. A RASS goal of 0 to -2, achieved using GABAergic medications such as propofol, benzodiazepines, or barbiturates, is recommended. The treating physician should always be notified if the RASS is -3 or worse. RNs who have validated alcohol withdrawal, SOS, and RASS competencies may use the SOS and RASS to assess patient symptoms and response to alcohol withdrawal treatment.
Inpatient hospital treatment for alcohol withdrawal is required for those patients at risk for or who are experiencing severe withdrawal complications, such as delirium or seizures of unknown cause, and/or severe medical or psychiatric comorbidity. Primary care treatment following a visit to a clinic or the ED may be appropriate for patients with limited risk factors for withdrawal complications, adequate psychosocial support, and a safe environment to which they can discharge. Be alert for patients with an active risk of suicide for which inpatient resources, including the acute mental health services, may be most appropriate. All patients in alcohol withdrawal or who are considered at risk for alcohol withdrawal should be monitored and assessed at least every 4 hours by SOS scoring for presence of withdrawal symptoms. If the patient is given a medication for alcohol withdrawal, for example, benzodiazepines or barbiturates, the nurse will need to reassess the patient within 30 minutes to 1 hour after the given medication and document their SOS score, and redose the patient with medication as needed until SOS score does not indicate the need for medication.
A higher level of care, such as acute versus step-down unit versus ICU status, could be considered for SOS scores that are rising despite evaluation and treatment, SOS scores of 12 or greater, or for patients who have exceeded 3 consecutive 1-hour doses of a benzodiazepine or 3 consecutive doses of a phenobarbital. It could be considered for patients who appear oversedated, such as a RASS score of less than -2, those who exhibit dangerous behavior, whose vitals remain with a heart rate greater than 110 beats per minute, or a systolic blood pressure of greater than 180 millimeters mercury, or a diastolic blood pressure of greater than 110 millimeters mercury, despite having received PRNs as prescribed. As a note, you should request that a provider come and evaluate the patient if any of the above situations do arise. Individual case variation may occur, including dose increases of the as-needed medication orders to gain better control. A change in level of care may or may not be indicated.
RNs will complete the initial alcohol withdrawal risk screen as part of the inpatient nursing admission screen note in the EHR. They will alert the ordering provider of alcohol use disorder identification test or audit C score greater than 5 and last drink within 24 hours of admission. The SOS will be completed in the electronic health record. Accurate allergy information will be reviewed by provider and RN on admission assessment. Any updates will be entered by provider or pharmacist. Alcohol withdrawal patients may be admitted to inpatient unit, step-down unit, or ICU depending on clinical needs after assessment of effect of initial management decisions and likely clinical trajectory. The initial medication or route of admission used, for example, benzodiazepine versus phenobarbital, oral alone does not dictate required level of care. Increased risk of seizures can be predicted by a prior history of such hyperreflexia or increased ankylosing.
Per the VHA directive for programs for veterans with substance use disorders, patients who are hospitalized specifically for management of withdrawal must have their follow-up appointment scheduled with an outpatient substance use disorder specialty provider within 7 calendar days of their discharge. Prior to discharge, make sure that you're advocating that the provider consider starting medications to treat alcohol use disorder in order to prevent relapse and reduce cravings. One medication you may see ordered to give the patient before they leave the hospital could be naltrexone. This drug can help to significantly reduce alcohol relapse and reduces consumption and cravings. Intramuscular naltrexone may be ordered to be given before discharge. This is a long-acting form and will last for 4 weeks. It must be given as a deep IM injection, so this is for gluteal administration only, and it does need to be given before the patient leaves the hospital. You can refer to the policy for more detailed dosing information and administration considerations for other outpatient medications, including gabapentin, acamprosate, topiramate, and disulfiram.
On this slide, you'll see a dosing flowchart for benzodiazepines. However, always be sure to go off what is ordered in CPRS. Benzodiazepine options for therapy exist within the menus in CPRS. Their dosing is based on SOS score. Oral diazepam and oral lorazepam options are available, as well as intravenous diazepam and IV lorazepam options.
Here's an example of the phenobarbital flowchart. This is in attachment C of the SOP if you want to refer to that. And this has been added as an alternate primary pathway for empiric therapy for patients at high risk for complicated withdrawal, or as backup therapy for patients with benzodiazepine-resistant alcohol withdrawal. You can also refer to the SOP or to lexicon for additional contraindications and adverse effects of phenobarbital. But some of the adverse effects that you should be monitoring for if you're giving phenobarbital is somnolence, ataxia, nystagmus, confusion, slurred speech, respiratory depression, or hypotension. Patients without a contraindication who are or will be hospitalized can be treated with phenobarbital for alcohol withdrawal syndrome. Phenobarbital administration, including providing a loading dose, is an appropriate medical treatment for alcohol withdrawal at any point and any setting during the patient's evaluation or inpatient admission. Benzodiazepine-resistant alcohol withdrawal or severe alcohol withdrawal syndrome, such as persistent SOS scores greater than or equal to 12, may be considered for higher level of care. Initial dosing will be calculated by the provider and the pharmacy in order to provide a loading dose.
Here are main areas of focus for when you are administering phenobarbital. Be sure to inject slowly, not to exceed 60 milligrams a minute, to avoid severe respiratory depression, apnea, laryngospasm, hypertension, or vasodilation with fall in blood pressure. Do not inject into small veins, such as those on the dorsum of the hand or wrist. Inject into a larger vein to minimize the risk of irritation and resultant thrombosis. Use proper IV injection technique to avoid inadvertent intraarterial injection, which has resulted in gangrene requiring amputation. Discontinue administration of injection if patient complains of limb pain. Doses larger than 260 milligrams need to be IV piggyback, not push. If required based on SOS and/or RAS assessment, you can give an additional 65 to 260 milligrams smaller loading doses until alcohol withdrawal syndrome is controlled. If a patient experiences recurrent symptoms, the provider may adjust the assessment frequency in the SOS order. Refer to the inpatient pharmacist with concerns about maximum inpatient dosing.
Documentation includes the initial audit C in the nursing admission assessment and further assessment of alcohol withdrawal severity using the SOS and/or RAS score, which will be documented in the electronic health record. Patients with a SOS score of 6 or below require an assessment every 4 hours and are appropriate for the acute care units. Patients receiving medication per policy will be reassessed 1 hour after each dose given until the SOS score is below 6 or is 6 or below. Patients will be reassessed 1 hour after each dose of any PRN medication, and a SOS score will be determined and documented at that time. Patients who are unable to participate in the SOS assessment, such as being unable to answer questions, will be monitored for increasing agitation or for adequacy of the pharmacotherapeutic treatments with the RAS score. The initial RAS score will be documented in Clinicomp or as a note in CPRS. RNs can begin using the SOS when appropriate. The goal RAS score will be 0 to 2, and this should be reflected in the provider orders. Patients that have a SOS score of 12 or above, or escalating scores despite the policy-based pharmacotherapy dosing, should be considered for a higher level of care. The patient will be monitored using the SOS score every 4 hours for 24 hours, and then every 8 hours as long as they are scoring 6 or below. This monitoring will continue for up to 72 hours from admission, or at minimum 48 hours from the last PRN pharmacotherapy dose. Maintaining IV access at all times for patients who have IV PRN medications ordered is important.
Here are important things to keep in mind of when to notify the provider. For inpatient status patients, notifying the ordering provider of any patient requiring greater than 3 consecutive every 1 hour benzodiazepine doses or reaching a cumulative dose of lorazepam, or assessment of oversedation to have them evaluated and considered for a higher level of care. For all patients with AWS, the RN is responsible for notifying the provider if the patient is difficult to arouse, reactive only to noxious stimuli, unable to follow commands, has a respiratory rate less than 10, a pulse ox less than 90%, or if medication dose seems inadequate. If worsening signs and symptoms of withdrawal, such as heart rate greater than 110 beats per minute, diastolic blood pressure above 110, tremor, agitation, anxiety, disorientation, nausea, or vomiting despite medications per policy. For behavior creating danger to self and others, be sure to refer to policy for restraint use. If 3 or more consecutive doses of PRN symptom-based withdrawal medicines have been required for reassessment of adequacy of dose in the regimen.
For the SOS score, you'll go through and score each section individually, and it will result in a total score. The image on the slide represents the CPR rest note documentation. However, we do have the SOS score available in Clinicomp, and the nurse can also document this assessment in Clinicomp. However, the questions that you're scoring for remain the same, so I'll use this to go through the questions. Starting with anxiety, remember that a lot of patients have baseline or general anxiety. If the anxiety is subjective, it's important to ask about how the patient is feeling right now. Right now, do you feel dread or that something bad is about to happen to you? This could help you to know whether to score them. For nausea and dry heaves or vomiting, again, you're going to ask them how they're feeling right now. When assessing for sweating, this could include moist palms, and you want to know if this patient is currently sweating. You can assess for tremor with the patient's arms extended and their eyes closed so that you can see if that tremor is happening at rest. For disorientation, there are 2 scoring possibilities. They can earn a score of 1 if the patient knows their name and place but not the date, or a score of 3 if they only know their name and they do not know where they are. For hallucinations, again, there are 2 scoring possibilities. Auditory only, in which case you would give them a score of 1, or if they're also having visual, tactile, or olfactory or gustatory hallucinations, for any of those you would score 3. With all of these, it's important that we check for a major psychotic disorder to see if there's another basis for these hallucinations. For the vital sign parameters, the parameters will score if they include any of the following: a pulse of greater than 110, diastolic blood pressure of greater than 90, or a temperature of greater than 99.6 Fahrenheit.
Here is a screen capture of Clinicomp's documentation for SOS scoring. As you can see, it's under the Neuro section within the Assessment tab. If you're not immediately seeing the scores options, you can add it.
The Richmond Agitation and Sedation Scale, or RASS score, is a validated and reliable method to assess a patient's level of sedation. The RASS is used to avoid over and under sedation. It can be useful in the patient experiencing alcohol withdrawal syndrome if that patient is not awake and alert enough to respond to SOS assessment questions. A RASS of -2 to 0 has been advocated in this patient population in order to minimize sedation. See the SOS order set for your patient to identify the provider's RASS goal. And here is where you will document the RASS score in Clinicomp for the patient. This will be under the Delirium tab, under Vitals, so make sure you're looking for it in the right area.